Yes, good evening, good morning, and good afternoon to everyone who joined this meeting, which is celebration webinar of the 10th anniversary of the World Pulmonary Hypertension Day. We are going to have a very busy agenda, so let me just start with welcoming our speakers, Irene from Spain, Professor Nazareno Gallie from Italy, and Professor Gerard Simeneau from France. You will see later on what is the common between the speakers. However, let me just briefly introduce what actually happened or happening just right now regarding the World pH Day. Many of you might have heard that we launched our position paper some days ago in the European Parliament. It was the revision of the original paper, Call to Action, which was launched in 2012. Now we have had the chance to review it and present it in the European Parliament. We devoted a special complete subpage for this event. You can see it on this slide. We are going to share this slide later on, but you can also easily have access to this page. We recorded the meeting. We also have some visuals, executive summary, and other useful information and materials to this event. We made a couple of visuals. Probably most of you have already seen on various social media channels. We prepared a timetable. It is so far translated more than 15 languages. So I'm really happy about this. And we provided with detailed timetable and text proposals how you can promote on your social media channels. We still have our online petition ongoing, which is a specific call to politicians and decision makers on all levels. Our call is to provide access to treatment and access to expert centers all over the world. And last but not least, we are preparing and have a very nice web page. It is completely dedicated to the World pH Day. It is available both in English and in Spanish. You can find lots of interesting and important information, also visuals, as I already shared with you, and other type of resources. Let me draw your attention to the World pH Day event calendar, so you can easily upload your event and share with us. And it is a very nice platform, so you can promote your events on that. So it was a very short introduction from my end. Let me just invite to the table our first speaker. And I told you that I'm going to let you know what is the common amongst these three people who are going to present today us. I can tell you the top secret. The top secret is that they were present 10 years ago in Madrid on the 5th of May, on the very first World pH Day celebration. And let me very welcome Irene Delgado from Spain, from ANHP Spain, and she will be the first speaker. The presentation of her is going to cover what actually happened and how they prepared for this very first event. Irene, the floor is yours. I think that you can share your screen if you try now. Or Alba,
Yeah.
are you going to help
Yes,
Irene?
Irene, que ya puedes compartir.
Thank you. Thank you, Gael. Ahí. Momento. Ay, qué nervio. ¿Se ve entera? No.
No.
Un momento. ¿Ahora?
No,
¿No?
no, se ve solo o sea, no se ve en modo presentación.
Sí, pues lo tengo puesto en modo presentación.
We are trying to put the presentation in presentation mode. Sorry.
Okay.
Dá-lhe as
No
jovens em
worries.
geral, como é que os chama?
¿Ya?
No,
Pero si lo hemos hecho esta mañana.
ya.
Ay, de verdad, lo sabía.
Si no lo podemos hacer así, no pasa nada.
Pero se ve.
Sí, sí, se ve, pero no en modo presentación.
Vamos ver como.
Bueno, pues lo hago así.
Okay. We are going to do the presentation with this mode. Sorry. Okay, because
No
we are-
worries. I'm going to share my screen, and I have your presentation. So no worries.
Dice que lo puede compartir él.
Vale,
Okay.
pero ¿cómo vas a ver cuándo hay que pasar?
Ya.
Can
But,
you see it now?
No, but Gegerli, we prefer to share us the presentation because we know when we must change the image. Do you understand me?
Yes, but I can
Okay,
forward it if it is needed on your end. So I'm happy to.
Vale, empiezo entonces, ¿no? Vale.
we are going to start, okay, Gegerli?
Okay, great.
Okay.
Thank you, I'm sure. Good afternoon to everyone. First of all, a big thank you to the organization of this event for this invitation. Today is a very important day, and I am extremely happy to celebrate and share it with all of you. Personally, it's also an honor to be here representing the Spanish National Association of Pulmonary Hypertension, an organization that I had the honor to found back in 2004, being the first of its kind dedicated to PH patients in Spain, and also the organizer and host of the first World Pulmonary Hypertension Day. And now, Alba will continue with the presentation.
So, as you all know, the National Association of Pulmonary Hypertension focused its work in the care given to the pulmonary hypertension patients. Back then, all the problems we found had a common denominator: ignorance and unawareness of this particular illness. Nothing new here, but any of you listening, and in general for anybody related to the world of PH. After we began to collaborate with PH8 Europe back in 2005, we soon became aware that we all face the same problems and concerns, all derived from unawareness about pulmonary hypertension. A problem not exclusive to Madrid, to Spain, or even Europe. This unawareness and, let's say, ignorance about PH was a worldwide common factor, and that is how the idea was born. At that time, in March 2011, we entered into a vicious cycle of believing what great idea was, but at the same time, being really scared with the size of the project in front of us. There was some time for doubts and fear, but our strong motivation finally pushed up towards it, since we knew from the very beginning how necessary and essential it was. So we roll up our sleeves and start to work. And the presentation is not sharing right now. La presentación no está compartida ahora, ¿no?
¿No?
Do you watch the presentation? No? No. Okay. Si no puedes, Irene, intento compartirla yo. If Irene can't, I try to share it.
Es que no lo entiendo. ¿Ahora?
Yes.
Now it's perfect.
Yes. Now it's perfect. Yes. But I need necesito otra. A ver, ¿por dónde voy?
¿Por cuál vas?
Por los objetivos.
Is
The
it okay,
objective.
Alba? Because I shared your presentation, so everyone can see now, I hope so.
Okay, thank
Can
you.
you see the presentation now?
Yes.
Yeah.
Okay, is it the right page you are talking
No,
about?
in the next
Next
one,
one?
I think.
Yeah?
Yes. Objectives? Yes, perfect.
So
Thank you.
please let me know when you need to skip and I'm going to forward the slides.
Okay, okay. Wait a moment, please. Okay. The objectives we wanted to achieve. Early diagnosis, so to avoid unnecessary deterioration and poor prognosis. The availability to all treatments, regardless of the hospital or country where required. Comprehensive care is not just a damaged organ. Develop specific reference centers, and above all, share and spread knowledge about these illnesses. Next image, please, next diapo. Thank you. This was an important question. We did not know what should be our first step, whether to contact and confirmation of the doctor, of the assistant, and guess, look for endorsement or financial support. This order seemed to be the correct order, but it has also its issues, because if we got all that we planned and all the support, but no funds, the money, everything will fall apart. And in the end, what we did was the next, please, Gergerly. Do it at once, simultaneously. Okay, but the first thing was to choose a date. Next one, please. Dr. Gomez Sanchez from the 12 de Octubre Hospital in Madrid was one of the first doctors to treat PH in Spain. He was the one who decided the date, May 5, the day when the first child with pulmonary hypertension died, victim of the toxic syndrome. Next one, please. Not only we had to commemorate a date, but we had also to decide what we were going to do. Our main idea and pillar to all that we might deliberate in order to commemorate this day. What that it had to be a day where all people related to PH had a place and felt identified with this day. 1. Health and healthcare, doctor, nurses, psychologists, geneticists, researchers. 2. Pharmaceutical industry. Thanks to them, we had financial support. 3. And of course, patients. But we didn't want to end up as many with the sample and unfortunately quite common event planning of all for the patients without the patients. Like most of the talks that were organized about to PH were the patients. Point of view is usually neglected. Don't we have a saying in all of this? News, the next one, please. Okay. Having all of this in mind, we organize a scientific symposium. Next one. Thank you. And let me say a very interesting one with many and different related topics such as new treatments, genetics, different research, nursing. To elaborate this program, but also to know how were the best, to know what was the most novel treatment, to choose the more interesting and novel subjects to make it more appealing. We were fortunate to have Doctora Pilar Escribano of the 12 de Octubre in Madrid, who helped us with the program. Again, thank you, Pilar. Celebration of the World Pulmonary Hypertension Day ceremony, next one, was a day where patients, next one, please. Yeah, okay. The celebration of the World Pulmonary Hypertension Day ceremony was a day where patients could attend and where we also could have the opportunity to be accompanying and to hear the experience and difficulties of the other patient association heads and presidents at international level. And since we were the organizer and host of the first World Day. Next one, please, Gregory. We included in this celebration a general assembly of our association. We also managed to get and launch with the National Post Office. Next one, Gregory. A legal tender mail stamp. To us, it seems the best and most original way to spread the word about our disease in Spain. Next one. Our guests come from many parts of the world, our doctors and patient association presidents. Next one, please. And of course, many doctors from different parts of Spain, of course, like Doctora Pilar Escribano, Dr. Barberá, Dr. Gómez Sánchez, or Dr. Ana Foul. Next one, please. After more than a year of work, the day has come. Next one. Prior to the start of the symposium, a press conference was held, which was attended by different media outlets that later published it and gave coverage in the news. The celebration of the International Scientific Symposium was a success where patients, next one, please. And next one. Thank you. Researchers and health professionals were able to share their research, 16 projects and studies on the reality of this disease. Next one, please. And pharmaceutical industry. Next one, please. Okay, next one. The fact that the program was conceived by patients also offered a novel and different approach to the symposium that were usually held until then. The scientific symposium was recognized as an event of health interest by the Ministry of Health, Social Service and Equality of Spain and the Line and Trago Agency. And now is going to continue Irene.
Thank you, Alba. Conclusions. The acknowledgement of a World Day of Pulmonary Hypertension was a step forward in the consolidation of worldwide awareness. This day was thought to improve the quality of life as well life expectancy of more than 25 million people living with this disease worldwide. Since then, every May 5, pulmonary hypertension organizations around the world participate in many activities to show their support, spread information, and help to improve the lives of people dealing and living with PH. Next, please. I do consider this day to be important because the objectives that were set, the opportunity to unite patient association with scientific societies, health sector, and laboratories, all at national and international level. This day is most important because the initiative and the organization came out from a small and modest association of patients. Please allow me to share and say that I am most proud of our association since I do truly believe this was a milestone in PH history. Next, please. It was hard work, a very long year, a lot of nerves, especially during the last previous month to the event, in case something fell. But in general, it was a marvelous experience that we were going through. The belief that it was worth it. That magic diminished the fatigue. We were as nervous as we were happy. When the ceremony and symposium were over, it was like when a deflated balloon. Everything was over. Everything went perfect. I confess that night, and as we say here, I slept like an angel, completely exhausted, but very, very happy. Also, next, please. Also, and very important to us, the fact that the first World Pulmonary Hypertension Day commemoration was done in loving memory of those who passed away. Our work will always be for them. Va por ti, Carlos. All PH patients, associations join forces every day to save lives and spreading knowledge about this disease. Next. Next, please. Thank you for your daily work. Thank you for listening me, and please, sorry for my English.
Many thanks, Irene, and Alba for this very nice memories regarding the first World PhD. I think that 10 years is very long time, and we can see that you started the World PhD in Madrid 10 years ago. However, nowadays we have more than 80 participants of this really and truly global event. And I'm completely sure that Nazareno will be also in the position to outline how long time, 10 years actually, and what really happened since the launch of the first World PhD. I think that everybody knows Nazareno, only one word, that he is a full professor of the University of Bologna, and I think that we are going to hear a very interesting presentation from Nazareno. I think that you can share your screen. I allowed Nazareno, so you can share your screen, and the floor is yours.
You see my slide?
Yes. You can.
Okay, thank you very much for this invitation. 10 years. I was also invited to the first. So it's a good opportunity to see the progress that we have faced in this field in the past 10 years or so. First of all, I will not discuss all the types of pulmonary hypertension, but only pulmonary arterial hypertension, because it's the field in which we had the most important progress, together with chronic thromboembolic pulmonary hypertension, and this is the task of Gerard, who will speak in a moment. So the classification of pulmonary hypertension is based on the difference also at the level of histology. In fact, if this one is a normal pulmonary artery, you see it is a pulmonary artery which diameter is less than 2 millimeters. The vessel wall is thin and the lumen is very large. And these are different types of remodeling according to the type: pulmonary arterial hypertension, left heart disease, lung disease, fibrosis, and COPD, and chronic thromboembolic pulmonary hypertension. So the clinical classification has a profound meaning, because also the treatment we know now is different according to the different types. This is the reason why the most important process in pulmonary hypertension is diagnosis. This is the algorithm of the old guidelines. I think all of you know that at the end of April at the European, and at the end of August at the European Respiratory Society and at the European Heart Society, the new guidelines of 2022 will be presented.
Hey.
However, the process is always similar. we start to identify the more frequent cause, left heart disease or lung disease. Then we try to identify patients with chronic thromboembolic pulmonary hypertension, and the rest are patients with PAH. And this is a cartoon with the most important trial performed in this area. So far, we have more than 50 randomized control studies, and this is extremely important because there are very few rare diseases with such large number of randomized control studies. And this is due to the collaboration of physicians, of patients who participate and are the most important part of the studies and industry. In addition, we have faced a progress in the quality of the randomized control studies. At the beginning, we had small studies, and they were quite short, around 20 weeks of duration. So this allowed us to bring to the market different drugs in a short period of time. And it was, I think, very smart to do so. However, more recently, we performed different strategy with larger studies, longer, which allowed us also to confirm that the drugs improves the outcome and the well-being and the quality of life of our patients. So there was an improvement in the quality of randomized control studies. These are the drugs who have been approved so far, and they interfere with three pathways: the endothelin, the nitric oxide, and the prostacyclin pathways. For the first two, we have oral medications. For the prostacyclin pathway, we have a different way of administrations because the prostacyclin analogs have fast metabolism. So it's not easy to identify non-invasive way of administration of these compounds, and often we need to recur to continuous intravenous administration or subcutaneous. And then strategies, because the drugs are very good, but we need to combine them in the appropriate strategies. So we started with one single drug, monotherapy. Then we increased sequentially, another drug or three drugs. And then we started with a very important progress, starting with more than one drug, usually two drugs or even three, at the beginning in treatment-naive patients to favor the effects. And more recently, we joined the risk stratification with the treatment strategy, again, to improve the efficacy of the treatment. Sequential combination therapy has been proposed in different studies. This is a study in which patients treated on monotherapy were shifted to double combination therapy or maintaining one therapy. And it's important to notice the improvement of the outcome. In this case, the patients enrolled had two drugs already, and the addition of a third compound also in this case provided an improvement of the outcome. And all these studies are new, of the new generation. The primary endpoint was outcome. And then initial combination. Initial combination also provide further improvement. And in the yellow line, you see patients who started with 2 compounds as compared to the patient who started with 1 compound. Also, in this case, there is a risk reduction of 50%, very important. And then risk-oriented. Risk-oriented means that we classify the patient severity according to different parameters, and we propose 3 groups: low risk, intermediate risk, and high risk. And the therapy is based on the risk. So, for example, for low or intermediate risk, a treatment-naive patients can be treated with initial oral combination. However, if the patient has an high risk, the drugs become 3, including intravenous prostacyclin analogs, in order to tailor to the patient the most appropriate treatment. And what about initial triple combination? Because based on studies of the Gerard Center, we had the proof that combining 3 drugs in severe patients, this provided an improvement, of the hemodynamics and also an improvement of the outcome. However, when we perform a study with comparing initial double combination therapy and initial triple combination therapy, we had in both groups a very important reduction of pulmonary vascular resistance and increase of 6-minute walking test, but there was not a superiority of the triple combination therapy as compared to the double. However, continuing to observe the patients, there was a proof, not a final proof, but a trend to the improvement of the outcome of patients on triple combinations compared to double. And in this case, there was not statistical significance because the number of the patients was not sufficient. This is why it would be important to repeat such study with more patients. And now I'm going to finish with the future, because we are interacting with 3 pathways, and we are on the quest for a 4th pathway. The 4th pathway may be the pathway of the BMPR2 receptor system, and this system is harboring the mutations for the heritable cause of pulmonary hypertension, and specific drugs is adjusting this pathway and sotatercept, and in a phase 2 study, an initial study, it was shown that adding sotatercept to patients already treated with 2 or 3 drugs produced a reduction of pulmonary vascular resistance. There are different studies ongoing, and the first phase 3 study, I've been told, has completed the enrollment, and probably the results will be presented in 1 year from now. And also in a category of patients in which no drugs were available, so pulmonary hypertension due to interstitial lung disease has been included in this study with inhaled treprostinil. And the results is an improvement of exercise capacity as compared to placebo. This is also a preliminary study, and we need to probably repeat it and to finally prove that also in this category of patients we cannot treat with the approved drugs because are not effective, may take advantage from the innate way of administration. So pulmonary arterial hypertension can progress rapidly in untreated or insufficiently treated PAH patients, and current PAH therapy is not able to cure the disease. However, it improves outcome if used appropriately. PAH therapy is not a simple prescription of drugs, but a continuous process including a constant reassessment of the effects of the drugs based on risk stratification. Use of double and triple combination therapy is supported by robust evidence and is recommended in almost all patients. Initial combination therapy with an endothelin receptor antagonist and PDE5 inhibitor is the treatment of choice in treatment-naive patients. And treatment escalation is required because if the patient has not reached the low-risk status. Low-risk status means that the patient is able to have a sufficient good quality of life. And this is our objective with all the treatment strategies. Thank you very much.
Many thanks, Nazareno, for this comprehensive lecture, and also thanks for the very promising future. I think that this is also very important for us to see that how rapidly we are progressing, and probably we will see the fourth pathway within the near future. Let me turn now to Gerard, who is a pulmonologist professor in the Le Kremlin-Bicêtre Hospital in Paris. He's going to talk about CTEP. I can recall that in some months ago, there was a very big discussion even about the terminology of CTEP and CTED. I think that we will hear lots of interesting things about the CTEP. Gerard, the floor is yours. Would you like me to share your presentation?
No, you have to, because I send you my slide.
Okay, then I'm going to share.
Okay, good.
Okay. Can you see it now?
Okay, perfect. Thank you very much. And it's my pleasure and honor today to celebrate with you the 10th anniversary of World PH Day. And today my topic is progress in one group of PH, the chronic thromboembolic pulmonary hypertension. Next slide. As you know, there is a five group of pulmonary hypertension in the clinical classification. And unfortunately, we have only drug in two categories, the group 1 of pulmonary arterial hypertension and the group 4, pulmonary hypertension due to pulmonary artery obstruction, mainly due to chronic thromboembolic disease. And it's probably in this field we have witnessed a lot of progress during the last 10 years. Next. CTEPH is a form of PH caused by non-resolving thromboembolism, obstructing pulmonary arteries after at least 3 months of anticoagulation. The pulmonary arteries are obstructed by fibrotic material due to non-resolved fresh thrombi. The incidence of CTEPH after an acute PA is around 2%. In fact, it's a rare complication of a frequent disease, acute PE. And it's relatively frequent. And in France, for example, we have around 500 new cases a year in the French network. Next. The natural history is important to understand. After acute PE, some patients, for unclear reason, have incomplete resolution and organization of the thrombi. It's not fresh thrombite, but it's a fibrotic material adhering to the wall of the pulmonary arteries, leading to stenosis, occlusion, and pulmonary artery. And the consequence of this stenosis and occlusion is a redistribution of the flow of pulmonary arteries through the open vessel, but this redistribution induces a microvessel vasculopathy totally similar to those observed in idiopathic PH due to stress. It's the same, roughly the same mechanism, but for shunt, cardiac shunt from left to right. And these two types of lesion, fibrotic lesion and microvasculopathy, increase progressively the pulmonary vascular resistance, right dysfunction, and symptomatic CTEPHs. Next. And now, recently, now we have three modalities of treatment targeting this different pathway, this different lesion. First of all, we have surgery targeting the fibrotic material in the proximal pulmonary arteries from main arteries to segmental, subsegmental arteries. We have also a new technique, angioplasty, targeting the fibrotic lesion more distal from subsegmental to arteries of diameter of 2 millimeters of diameter. And we have also some treatment now targeting the microvasculopathy of muscular arteries of less than 0.5 millimeters of diameter. And these lesions are very similar to those observed in idiopathic PH. Next. Pulmonary endarterectomy is a gold standard treatment for operable patients. And now in a very selected center, we can have this surgery in distal disease from segmental to subsegmental pulmonary arteries. And as you can see, in every type, we have a major improvement in hemodynamic between 85% decrease in PVR to 57. Interestingly, the postoperative mortality now is less than 5%. Next. In 2016, we have published a multi-center registry comparing patients with proximal disease treated with surgery versus distal disease treated with medical therapy. But at this time, no drug was approved. It was off-label use of ERA and PD5 inhibitor. And as you can see, at 5 years, the prognostic is much better in operable patients, 96% of survival versus 58% for patients with non-operable disease treated with off-label medical therapy. Next. Next slide. Regarding medical therapy, recently, the riociguat, a guanylate cyclase stimulator targeting endopathway, was approved in 2015 for the treatment of inoperable CTEPH of persistent recurrent PH after surgery. More recently, subcutaneous treprostinil targeting the prostacyclin pathway had been approved in 2020, but we have less long-term result with this drug. And today we are providing a parenteral treatment option for patients in functional class 3-4, and those who do not tolerate other therapies and need to have combination therapy. Next. For riociguat, we have long-term data because all the patients including the CHES-1 of the pivotal study leading to the approval of riociguat. This patient enter in a long-term study of 2 years of follow-up. And next one, next slide. For this selected population, we have a survival rate of 93% at 2 years. It's an excellent result. Next. But for distal disease non-operable, we have now a new technique available, balloon pulmonary angioplasty, like for coronary arteries, but more complex than for pulmonary arteries. BPA was first developed for treating congenital stenosis of pulmonary arteries. The first case series published for BPA in CTEPH was in 2001 in US, but with some result not ideal, with high rate of severe complication. However, over the last 10 years, several centers in Japan are refining this technique, leading to improvement in efficacy and safety of BPA, leading to new treatment options for inoperable CTEPH. Next. And now we have some series published, not very large series, not cohort, but two large series are in Japan and in France. And as you can see, most of these patients were treated with medical therapy before inclusion in the cohort. Next. In terms of efficacy before and after BPA, generally we need to have 5 to 6 sessions of angioplasty to have a measure improvement. And as you can see, the improvement is highly variable from one center to another center according to the learning curve for this disease, but improvement from 65% to 28% in some center. Next. The one problem of this technique is the complication. The most frequent complication is lung injury. As you can see, it's characterized by localized dense opacity on CT scan immediately a few hours after BPA. Severity highly variable, sometimes asymptomatic, sometimes needing mechanical ventilation and sometimes circulatory assistance, and associated with or without hemoptysis. Next. This complication is frequent, occurring in 38% of patients, with a mortality between 0 and 5%. And what is important to observe, this complication is totally related to the severity of pulmonary hypertension before BPA. And as you can see here, higher is a mean PAP, higher is a PVR, higher is a risk of lung injury. Next. The next slide. This complication has been well studied by the group of Matsubara in Japan. And in 76 patients with lung injury, these patients were sought by performing systematic CT scan after BPA, and lung injury was detected in 75% of patients with highly variable severity. And interestingly, angiographic findings show extravasation of contrast media, and this lung injury is in fact a lung vascular injury. And here again, there is a clear correlation between the severity of pulmonary hypertension and the occurrence of lung injury, more frequent here, 42 versus 36, 11 of resistance versus 8. Next. In our center, we have analyzed the initial experience of and the survival in patient non-operated. From 2006 to 2016, we have analyzed 343 patients newly diagnosed consecutive with non-operable CTL diagnosed and followed during 5 years in the French Referral Center. And over long-term survival, we have analyzed this data, comparing the early period between 2006 and 2012 versus recent period since 2013. Is it interesting because between 2006 and 2012, we have no treatment available, only off-label medical therapy. After 2014, we have the possibility to have riociguat approved, but also the development in a BPA program angioplasty in our center. Next. And what we observe, if you compare mortality in survival in the two period, the early period is improving as compared to the previous period. and with 85% of survival at 3 years versus 75. And what is important in terms of improvement is to receive riociguat and to have BPA. And today in our center, we have performed now BPA in 660 patients. It's the largest experience worldwide with a group of Matsubara. And today, the survival rate in non-operable patients treated with riociguat and BPA in association. Generally, riociguat first line to improve hemodynamic and to decrease the complication of BPA. The survival rate is more than 90% of survival at 3 years. Next. And is a survival of the initial experience. And we have observed 7 deaths and 4 deaths related to procedure. But today in recent data analyzed in 160 patients, we have no new deaths for 2015. Next slide. In summary, in current in the CTEF, with the better knowledge of the pathophysiology of the disease and the distinction of fibrotic clots and microvasculopathy, fibrotic clots in proximal vessel and in distal vessel, we have a major progress. And inoperable patients today, representing 60% of CTEF patients referred in referral center, PS is a treatment of choice with postoperative less than 3%, despite a patient population with more distal disease and starting at the segmental and subsegmental level. In non-operable CTEF, due to the combination of medical therapy and reified balloon pulmonary angioplasty, the survival rate now has markedly improved today. And in high volume center, survival rate is around 95% at 3 years. But today we are entering in a new area in this disease with the possibility to combine in the same patient multimodality treatment. For example, pulmonary endarterectomy and medical therapy, or medical therapy and BPA, or rarely a triple combination of medical therapy, BPA, and PA, outlining the need to evaluate this patient during a multidisciplinary meeting, including surgeon, angioplastician, cardiologist, pulmonologist specialist in pulmonary hypertension, and radiologist specialist in pulmonary vascular disease, and to propose this different type of treatment option in the best condition and for the best result for patients. Thank you for your attention.
Many thanks, Gerard. I think it was very interesting, and it is fantastic to see regarding CTEP that how nicely supplementing each other, the various interventions, as well as the medical treatment.
Yes, because 10 years ago, we have no treatment, no treatment except surgery. And now we have the combination of surgery, angioplasty, medical therapy approved with 1 and now 2 drugs. And I think it's a real progress in this group 4.
Yes, actually, I was very optimistic regarding when I was building up the agenda, because we completely ran out of time. I do not know. I just checked the chat. I haven't seen any questions related to the presentation, but rather some technical ones. But if someone has any questions from the audience, we are happy to take. If not, I'm waiting for a couple of seconds. Let's play a bit, because I have lots of new names within us. So let me ask those who are patient representatives or carers, or have any relatives, PH relative, turn on the camera, and everybody should turn off, so we could have a better understanding of the PH population now within the call. let's try it. And I'm trying to make a screenshot about it. I see lots of familiar faces and names. It's very good to see you, and I'm really happy to see new faces as well. Okay, then let's play on another side. So please, who are physicians or students, please turn on the camera, and everybody should turn off. Let's see how it works. It seems that the doctors are shy in these late hours. Anyways, let me thank again Nazareno and Gerard for this presentation. As I mentioned in the agenda, we have a surprise for today. Let me try whether the technique will work. If not, probably Hal might be in the position to help me, because he is always backing me with such kind of difficulties. But please give me some seconds, and I try to make it happen. Now we are almost there. I hope now it will work. Can you hear it?
Yes.
Hey, hallo.
Ik kwam net uit, of niet?
Ik
Waar stond de auto er al?
So this was a very small surprise from our end. The video is so far in a private mode, but we are going to make it available very soon, so you can easily revisit, reshare, and start some discussion about it. I really hope that you also enjoyed. It was a very good feeling working on this with our partners on this. We are really coming to the end of this celebration, and I really hope that you find the presentation as well as this video heartwarming and very interesting. Let me thank again for everybody's efforts to make the World PhD really a global initiative. Let me thank our physician partners who are helping day by day us. And let me also welcome and thank all the efforts of the patient community who tirelessly raising awareness of pulmonary hypertension, stepping again and always next to the patients, providing peer-to-peer support, which we learned is very important. Let me thank again for your participation. The World PhD celebration is not end with this webinar because lots of other activities are still ongoing. Let me wish you a very happy evening and enjoy your evening. I know that in lots of countries and cities, we illuminate the buildings in blue. So if you are working on that, please share with us, and we are going to make a post about this tomorrow and celebrate the World PhD also in this way. Many thanks again for your participation. Wishing you a very nice evening. Goodbye.
Goodbye.
Bye.
Bye.